Welcome to the Parenting at Mealtime and Playtime Quality Improvement Project and this webinar on laying the foundation for improvement and how we can help you create a climate for change within your clinical setting. In this webinar, we're going to take some of the information that you've learned thus far in your online learning environment and bring it together to start your improvement journey. By now, you should have attended a pre-work presentation, either via webinar or a live training, which provided an overview of this project, its aims, and resources that are available, gave a description of KEDA's main pages, and how the data you've abstracted from your charts will be entered into the system. You are now at the point where I will review several elements that will help create a favorable environment for not only testing changes, but for sustaining them. Throughout this and future webinars, I'll address elements for sustainability and provide suggestions for making the most of your improvement efforts during this initiative. If you are interested in learning a little bit more about quality improvement, there is a link that I've provided within the KEDA module, Pre-Work and Baseline Data Collection, entitled Quality Improvement Basics. You can view this to get a little more background or brush up on any information with quality improvement methodology. This webinar here will orientate ourselves to the aims that are within the key driver diagram, what and how baseline will be collected, and several action items to consider as you complete this initial module and begin the e-learning session. I like to start each quality improvement initiative by bringing to the forefront of all of our minds the global aim that we're trying to accomplish. If you remember our discussion of the theoretical framework called the Model for Improvement, it was essential to hone the vision of those that were working on a project so that we're all looking at the same task or purpose. The overall or global aim for this project is to achieve optimal health for and prevention of overweight in young children through early identification of risk at all well-child visits, birth through 5 years of age. The specifics of how we intend to reach that goal and the interventions to do so are noted within our key driver diagram, the roadmap to this improvement project. This slide, and I'm sure you've seen this in our previous webinars or our introductory work together, is the roadmap for this initiative and is the Parenting at Mealtime and Playtime's key driver diagram. You can see the global project aim is listed in the bottom left corner, the one we just discussed on the previous slide. Directly above this global aim are the specific aims for this project that center around improving risk assessment, providing age and appropriate anticipatory guidance, that we really try to focus on 3 key elements of diet or nutrition, daily activity, and having a structure and sleep system in place for your children. And when appropriate, utilizing motivational interviewing strategies and goal setting to facilitate change in the families that you're seeing during your well-child visit encounters. These final 2 aims of motivational interviewing and goal setting, as well as following up on the goals that have been set at previous visits, do not really require that your chart audits are done over a longitudinal tracking system or view data long-term, solely looking at randomly selected charts, but it does encourage a review of your medical record prior to seeing each patient to ensure that any goals that were set at a previous visit, be it by you or another provider, are appropriately addressed and followed up upon at this current visit. The remaining elements of this document focus on the key driver diagrams of providing age and developmentally appropriate preventative care and anticipatory guidance, having an appropriate risk assessment to evaluate what the risk is for excess weight gain, and if it's appropriate, intervening at an early age for obesity management. And the best practice interventions that you, or should you embark upon this with a core quality improvement team, that you guys could trial within your practice are in this final column on the right-hand side, the interventions. And these will help you improve the measures that are listed in the SMART aim and that are captured within your chart reviews. For instance, When we're looking at risk assessment and appropriate documentation that assessment occurred, that might be an area that you would like to improve upon, having looked at your baseline data and what goal we're trying to achieve, 95%. In the second box on this right-hand side of the intervention column, you may choose to work on any component of this comprehensive risk assessment. So it's this final bullet of assessment of obesity-related health risk, of which there are 5 sub-bullets. You may want to work on improving your documentation of weight for length for those less than 2, assessing and recording BMI percentile for those older than 2, for those kids that are older than 3 years of age, screening and interpreting a blood pressure. You may want to explicitly document what the weight status is of that child and how that correlates to their growth trajectory, or looking at the child's obesity-centric family history. Those are all elements that you could work on individually or collectively that would really help you improve and provide notable improvement in that documentation of obesity-related health assessment. So then you can use those items to configure within your office flow and then how to best and sustainably document your work. The key driver diagram, or the roadmap to this quality improvement initiative that we just addressed on the previous slide, will be distributed over the course of the 7 modules that you complete within this PMP KETA. While this all can be completed on an individual practitioner level, we have found PMP to be most successful if you try to do it in a collaborative or team environment. Even if that simply means recruiting another physician or someone from your nursing staff to join you for this endeavor. There are various components, from providing a diet and activity history collection form that are age and developmentally appropriate specific to the well child visits you'll be doing the anthropometric assessments, BMI, weight for length, or blood pressure, and the documentation of the actual counseling, any potential goal setting, or handouts that are provided, that we find it may be helpful to have additional people within your clinical setting involved, kind of fostering and getting that buy-in very early on, especially if this is something you would like to continue, and we hope that you do. I'll be discussing the importance of teamwork on the coming slides. Each module that we have, and those are listed at the bottom of the diagram of this slide, starts with a brief overview of the work that you'll be completing for that section, what it entails. Be it viewing a webinar like this, for the initial components, submitting your baseline or improvement data. You will progress then through this preparatory period and modules, collection of your baseline data to hone your goals, and your scope of work. Then the next module, the second one, will provide some research in our e-learning session and the literature that supports PMP messaging, as well as the links to all the PMP resources. We've walked through some of those on our introductory calls and webinars and trainings together, but all those are listed there for you to access electronically. From there, the action period will begin, and those are modules 3 through 7. At this time, you'll determine the changes to make, evaluate, observe, and document your office flow, and view a series of webinars that provide not only additional skills or knowledge that are specific to PMP and you work with your young patient population, but some quality improvement methodology as well. Data collection will also occur during these modules to help you inform the next step test of change that you may conduct and how that impacts your improvement efforts. These will occur throughout modules 3, 4, 5, 6, and 7, so that you have 5 total cycles comprised of 6 charts each to be submitted to the system. The final module, number 7, is your sustainability module, and how you can embed what you've done over those past 6 modules within your practice and maintain the best practices that you have made.
To reiterate what I mentioned on the previous slide, this collaborative is self-directed and at your own pace, but we have found people to be more successful in their improvement efforts if they approach the upcoming work as a team. If you decide to pursue this as a solo provider, it may be helpful to keep this information and the following information in mind as the collaborative KETA wraps and you seek to spread your improvement effort or scale it up for sustainability. With that in mind, and moving within the approach of using a core quality improvement team, it takes time to identify the right people who will assist in testing changes during the collaborative and who will support and implement for sustainability of improvements post-collaborative. We have several people that we think are helpful to consider in your core quality improvement team. We try to have an interprofessional team, and it may be comprised of administrators, office managers, your clinicians and nursing staff, social workers, anyone who you think will be instrumental to your improvement efforts. We encourage having a champion who will help be the momentum behind your improvement effort. Typically, these are lead physicians, but it's not limited to a physician. And then having persons with technical expertise to maybe help with the KETA online learning environment and any of the tools that you'll be using throughout the collaborative. And finally, thinking about some senior leaders, sponsors, or leadership to engage, maybe not for just the improvement effort, but for sustainability. And keeping in mind that your team members should be knowledgeable about the system, have a stake and are invested in this effort, and really view improvement work and the efforts that they'll be doing as part of daily work, not just something extra that's laid on top of their workload. And try to select these individuals with the aim of your collaborative and maybe what you would like to accomplish in mind so you can help feel empowered and empower those for success.
This slide just provides additional information of what we covered on the previous slide with the core quality improvement team being inter and multidisciplinary, and addresses the essential elements of system authority, clinical or technical expertise, and day-to-day leadership that are potential individuals and the hierarchy of those individuals to include not only on your core quality improvement team if you choose to go that route during this testing phase, but maybe as you work for sustainability. And try considering one or all of these folks to include to make the most comprehensive team and give you the best foot forward in a team-centered approach.
While I realize that we're just starting our improvement journey, it's helpful to think of the endpoint in mind as we begin, so we build sustainability factors in from the start, one of which is leadership. And one key to success is having a leader on your core quality improvement team or even higher up, especially on the ground, who can combine the technical quality improvement skills with those skills that are needed to help manage people during an improvement effort, having effective interpersonal and relational skills. There are two types of leaders, those that are adaptive and distributed. Adaptive really thinks about what is needed to help modify attitudes, values, and beliefs of those people working and the culture that surrounds them, versus distributed. Leaders who are at every level and can really help drive the spread of change more technically. So taking those two components and meshing to find one high quality leader on the ground and higher up that can help promote this improvement effort. Thinking further on the sustainability factor of leadership, there are 5 planes of engagement that a leader should consider: social, spiritual, psychological, physical, and intellectual. At the social level, we're looking to build on the energy of personal relationships and connections with individuals. At the spiritual level, really valuing the work and inspiration that drives people. Psychologically, on the courage, trust, and feeling safe to work on an improvement effort that may be out of your comfort bounds. Physical, the energy that it takes to actually do this work and to make progress. And intellectually, using the evidence and reasoned argument, having all 5 of these skill sets to foster a relationship and connect with people on your core quality improvement team. It's essential to have these to help get people engaged, have commitment to the effort, and to motivate them moving forward. Getting people engaged and maintaining that engagement and buy-in is somewhat of a struggle for some people. And a key to success is to find those with a vested interest and have them be a voice not only on the improvement team, but on your sustainability and spread team. Leaders should be able to know whether the crowd they're working with and for to make sure that the test of change and ultimately spread ideas align with all the feelings, thoughts, and behaviors of all the stakeholders involved. Connecting with people to see and feel a link between what matters to them and what matters to the organization, so everyone's aligned. Looking at the content, the organizational energy can also work from the social movement theory to refer how the actual tasks people are to do are enjoyable and challenging to them on an individual level. The context is about how far the way the organization operates and the physical environment in which the people work make them feel supported. What is that difference? And the climate refers to how the people do things around here and encourages people to give their best. It's really important to give reminders on the importance of this issue and the positive impact it'll have as everyone is engaged. Leaders should always be thinking about how you can connect with people to remind them about this, and communicating with people and making them feel that they are a part of this change effort and their role is instrumental to this process. And you can do that through another sustainability factor of empowerment. Hear, listen, and respond to not only those on your core quality improvement team, your sustainability team, and spread team, but the patients and providers that are involved. Make the effort personally meaningful for all them involved, highlighting their requirements and shaping it to their beliefs. Again, a strong skill set of a leader. Experiences and personal views really drive the improvement process, those in and those who use the organization. So not just for the providers that are working on improving this. Use pre-existing skills and knowledge to kickstart an individual's competence and their competency to perform the required improvement actions. And in shaping your team, during team meetings and importantly during brainstorming efforts, test of change, and analysis of change efforts, encourage everyone to provide feedback and feel autonomous in this process. Highlight how each individual can influence the collective improvement effort and sustainability effort, and what impact their role has towards achieving our short, immediate, and long-term goals that may have been highlighted in your evaluation plan. And in creating a culture for empowerment, a deliberate effort should be made to listen to your team and patients impacted by this effort. As approaching this collaborative, involve your team from the get-go, if you haven't done so already, or involve them from the sustainability and spread point to bring individuals to the fold as appropriate and listening to them when it comes time to decide where to focus the improvement and sustainability work on, picking what items to test and to spread, and evaluating these efforts. The more you can do this, make the team members feel a sense of ownership, the more likely they are to identify problems, continue developing ideas, and harness the energy for all the work that has to be done.
My hope in covering the previous slides is that I may have influenced your decision to move forward with this PMP Quality Improvement Initiative as a team rather than individually. If not, you're still going to be great and successful in your work. Either way, there are a series of items to complete as you begin this process. We have pre-work surveys. It's a very simple survey about the background of the office systems and processes that you have in place to support obesity prevention and weight management. Within the KETA module for the second section, there is also a Word document that contains some of the questions that will be asked about your practice environment and the patient population. It may be helpful, especially if you're doing this individually as a solo practitioner, to print off that document and the questions that we'll be asking and have someone from your administrative staff assist you in completing the information if you don't know the information. And then you can go back to the SurveyMonkey pre-work survey and fill in all that information as you complete the other office systems and processes. The second main component is your baseline data. We like to do 2 cycles of data, and these will be 12 charts in total, and each cycle of data consists of 6 charts. We are looking to kind of give you a good glimpse of how consistently or maybe inconsistently you are in documenting the items that we're looking within these chart reviews. We are looking at one chart from each of the suggested well visit age ranges, and those are included on the KETA module, so you'll know how to pull those charts. One example of that age visit range is the newborn to 4 months. You'll take one chart from that. And then there are 2 specific months that you'll be pulling data from. For your first cycle of data, you'll be pulling charts from the month of August 2017. And from your second cycle of data, you'll be pulling 6 charts from September 2017. Then, as you've collected that information, you can abstract it onto a printed off version for each of those 6 charts and enter on the KETA homepage for the collected months. Again, cycle 1 being from August, cycle 2 from September, each consisting of 6 charts from the targeted well-child visit ranges, and you'll enter those on the project homepage.
We have a series of measures that we'll be working to improve within the Parenting at Mealtime and Playtime Learning Collaborative. This is the Well Child Visit monthly chart review tool. You'll use this for your baseline and action period cycle data collection. Walking through this, you'll note the well child visit that was attended, the caregiver that was present, gender, and the timing of year of visit. We'll be looking at several components around risk assessment, the anticipatory guidance, and your motivational interviewing and goal setting. Within risk assessment, you'll be looking at documentation of weight status, growth trajectory, blood pressure categorization for those children over 3 years of age, and family history to note the global risk that may be present within this child and the family. On the left-hand side of this chart review tool, noted with the please check all the appropriate boxes based on what was documented for the encounter, you'll note the appropriate items that were explicitly documented within your chart. If you did not have a component, you can leave that blank. There is a not documented or nothing documented option within the actual chart review entry. On the right-hand side of the tool, there are some specifics of information to also include. These items may not be explicitly documented, but you can figure out this information and it'll provide a more global picture and help you think upon some things as you work to evaluate obesity risk assessment and the anticipatory guidance that you're providing. Moving on to the anticipatory guidance, we look at nutrition and activity and daily structure. On this slide, we have nutrition. Very similar information will be gathered for diet and daily structure, and I'll address that on the next slide. Nutrition looks at the use and review of your PMP intake forms or your healthy habits forms, discussing age-appropriate dietary behaviors, and whether or not a PMP handout was provided at this well child visit, and noting the nutrition topic most discussed or most focused on for this well child visit. Similarly, looking at activity and daily structure, you'll note that the same things are completed here, but for activity. The final portion of your chart review will consist of looking at motivational interviewing and goal setting. Based upon the child's risk assessment and your review of activity and dietary habits, you'll determine whether or not you feel that a behavior change should be made and evaluate the family's readiness to make a change. Families may be on the right path, having a healthy weight, the child is on the same growth curve, and all their diet and activity behaviors may be optimal, so a goal may not be needed. Also, a family may decline setting a goal, and you've noted as such. So that will conclude your motivational interviewing component. There are several factors to discuss within the motivational interviewing. Your use of open to closed questions, how much of a collaborative environment you made with the family and the patient, and some of the motivational interviewing techniques you used. This information will be covered at depth in Dr. Chris Bowling's motivational interviewing webinar. We also look at goal setting. So again, if the family was found to be making a behavior change and they were ready to make a change, you can work on setting one specific goal that the family can walk away with and trying to phrase it as a smart phrased goal. Specific, measurable, action-oriented, relevant or realistic for the family to achieve within a certain time frame. You can note the components of goal setting that you've documented, And then on the right-hand side, note what the smart phrase goal topic area was that you selected to work on with the family. There's also a portion here on goal follow-up. While this may not be pertinent to the current visit for a child, there may have been a visit in the past, the most recent one, that the family made a goal and you should follow up on. Again, there may not have been a goal set, or the family declined on setting a goal at the previous visit. Either way, following up on that to see what the outcome and progress was around the goal that they've made. Within the goal follow-up, if they did decide to choose a goal and to work on it, figuring out what stage of change the patient is in regarding the goal set at the previous visit. If they were able to maintain the goal, if they're working on it actively in action, preparing for it, thinking about it in contemplation, or starting to think about it in the pre-contemplation, noting what phase that family is at. While I discussed the measures very quickly, we have a measures table that walks you through what should be included to say that you documented something and to check an appropriate item was explicitly documented within your chart. This is a screenshot of all 9 of our measures. And here I have in more depth looking at, for example, weight status, what would need to be documented to check appropriate boxes. So you can check the box for each item that was explicitly documented within your chart: the child's weight, length or height dependent on age, the weight for length or BMI percentile, again dependent on age, and having weight status notated. There's a note here for weight status that in order to select that box for weight status, you must have explicitly noted within your chart one of the following words based on the child's weight for length or BMI percentile, if they were underweight, healthy weight, overweight, or obese. With this type of thinking in mind, we've laid out the other measures to note what types of things should be included to say you have documented appropriate items.
Here, I would like to reinforce the concepts that I just covered in the previous slides as I went over the measure definitions within the measures table. If you still have any questions about what counts or doesn't count, what you're specifically looking for in this check all the appropriate boxes column or the more precise information column on the right, please feel free to reach out to anyone on the PMP project team and we'll direct you to the person or myself that could answer these questions. The example that I used was specific to weight status. So in continuing with this example, in using the chart review tool to abstract your information from a child's chart, in this example, I'm going to be looking at a 4-year-old. The following information would have to be written down in the 4-year-old's chart in order to check the boxes I'm going to address. So I'm looking through the child's chart, and I was able to find that the child weighed 35 pounds and was a height of 40 inches. However, I did not find a BMI percentile, be it written somewhere within the chart or the progress note, or even annotated on the growth curve, or that the child was specifically noted as being healthy weight. Given this information, in looking at the column that says please check all the appropriate boxes based on what was documented for the encounter, and in the weight status box, the first one, I would only be able to check the boxes of weight and height. I note the specific weight of 35 pounds and the specific height of 40 inches. As you're putting this information into KEDA, you also will have to note the specific units of measurement. So pounds and inches were used for this child, where you may be using metric of kilograms and centimeters. Just important to note those moving forward. Despite not having that explicit documentation of the child's healthy weight status, I can't check the weight status box or the BMI percentile box in the left-hand column, but as I move to the right where it says please fill in more precise information regardless of whether it was explicitly documented, I do know that this child was of healthy weight. So I'm going to select for question 1A, healthy weight. Now that we've taken some time to go through the PMP chart review tool and what the specific measures we're capturing as they relate to the key driver diagram and what counts and doesn't count in terms of your documentation within your charts, I'm going to walk you through the KEDA environment, again, a refresher based on some of the previous discussions that we've had on how you can use this environment, the project homepage, to enter your data, the workspace to get the tools that you need to abstract the information, and then how to close out cycles and look at your data. We'll go into a little further depth about data analysis in a future module, but I'll allude to it here in case you have a few extra moments and you want to explore on your own. So after having logged in to the PMP site, again, qidata.aap.org/Ohio PMP, logging in with your ABP ID or email and your password, you'll land on this project homepage. The main purpose of this homepage, again, is to enter your data. Our data collection tools are noted here, and we really just have the Well Visit chart review tool. What you can do in terms of looking at your data, if you haven't already abstracted your chart information, you can go to the workspace. And within the workspace, there's an opportunity to download the chart review tool in a paper version and print it off so that you can review your 6 charts for August 2017 for cycle 1 and your 6 charts for September 2017 of cycle 2. Put it on that paper chart review tool, then come back to this KEDA system to enter the information. Of course, you can always direct entry by looking at your EMR or paper chart and putting that information into the system. The one caveat with that is you don't have a backup to kind of go back and review your data and see, at least the paper version, what you may have missed and opportunities for improvement. It just depends on how you like to approach data entry. So you can download the chart review tool here. Again, same one that we've discussed in this webinar, and go through and note the elements for those 6 charts that you review for each of the first 2 cycles. Once that's complete, you'll come back to the project homepage and scroll down to the chart review tool. I have cycle 1 currently open, and I've entered 6 charts so I can show you what to look for as you're entering your data, as well as how to close out the cycle. So I'm going to walk you through my last chart that I've entered and the different components that I put in there. Since I haven't closed the cycle out, you'll notice I'm on chart 7. You're only required to do 6 charts. However, you can do more if you feel it'll help inform your improvement efforts, but it'll always, once you close out or complete a chart, move you to the next chart. So I'm going to go back to chart number 6. It'll show me when I've completed it, but I still am allowed to edit it so long as the data cycle is open. Once you click this Close Data Cycle button, you cannot go back and edit the data. So for this example, I had a 5-year-old child. Dad came to the visit, and since this is cycle 1, month of August and the year 2017. Scrolling further down, it was a male child. I noted his height, weight, and I had his BMI percentile in here. However, I did not have a weight status noted. Even though it wasn't explicitly documented, as in that example I showed earlier, because he is at the 88th percentile, he's classified as overweight. Going through the other elements of the chart review, we have growth trajectory. I had a discussion on updating the growth curve since the last well visit and discussed his child's growth relative to the last visit and noted some change given that there was an increase in his growth curves. He is over the age of 3, so there was documentation of his actual blood pressure readings. However, I missed averaging or having multiple readings. And while it shows zeros here, if I went back to edit it, I'd see the actual systolic and diastolic readings. But I did have at least one reading for systolic and diastolic blood pressure. However, the element that I was missing was noting his specific blood pressure category. While I missed explicit documentation that this child was normotensive, based on his height percentile and systolic and diastolic blood pressure, I know he was normotensive. Rounding out the risk assessment, we have family history. I updated his information and did another obesity-centric review of his family history.
Some of the other items to note, one of the positive findings this time was high blood pressure in the family. Going on to the second element that we're looking to capture, items 9 and 10, which are very similar to each other in terms of what we're looking for documentation, and this is baseline. Use and review of PMP nutrition intake or healthy habits forms. Since I'm just starting, I didn't have those items for nutrition or activity. I did, however, for both of nutrition and activity, discuss age-appropriate behaviors. I did not have a PMP handout. Again, this was baseline, so I didn't select this box. But I did note in the subtopics of 9A and 10A what my specific nutrition and daily activity topics were. If I didn't have something noted for those, you can see in the parentheses, I could note NA or main question was not documented. Either way, just so that something's filled, because these are required forms. The final elements were motivational interviewing, our goal setting, and goal follow-up. Something to pay attention to these components are the use of the not applicable options. So to count for motivational interviewing, if it's appropriate to do it with the family, you're going to have to select, if you've done it, use of the readiness scale or ruler to rate the family's readiness to make changes. However, the child, and not in this example at least, may be of healthy weight, on the same growth curve, and all their behaviors are optimal. So there wasn't a goal that's needed. You could select that option. Or you've gone through the motivational interviewing process with the family, may not have documented the use of the scale or ruler to see how ready they were to make changes, but the family declined setting a goal, and you noted that. So you attempted, but there wasn't a response from the family. So NA is an applicable option here. Overall, too, if you didn't have the use of the readiness ruler but did set a goal with the family, you'd select no documentation. Some of the additional elements that we're hoping to strengthen the counseling process are your use of open to closed questions, the degree that you formed a collaborative environment, and maybe some of the techniques that you used. In reflecting on your encounter with the family, you may note that you used open-ended questions and reflected on the patient's values, so you could select those. But you may not be able to think about the use of your open to closed questions for 11A, so you just select NA or the main question wasn't documented. And then to the degree that you formed a collaborative environment, you thought you did a pretty good job and we're right in the middle, so you selected a 3. Similar to the above motivational interviewing, the family declined setting a goal, so I would select not applicable, so you don't essentially get dinged for not doing something. You can't document items if the family wasn't ready to make changes. And since you selected NA, when you got down to 12A about the goal that was selected, you would also select this NA option, or the main question was not documented. The final question of this is looking at your goal follow-up. So was there documentation of a goal that was set at a previous visit? This is the first time that you may have needed to set a goal for this child, and in looking at the past encounters, didn't see anything. So not applicable is the appropriate option here. And then again, all the sub-questions, you would note not applicable or select the NA or main question was not documented option for 13B, 13C, and 13D. If you had a goal follow-up, there would be logic built into this that you would have to answer this question. All the elements that are contained within a chart review are noted in reviewing an entered chart, so you wouldn't need to necessarily see or have these components if it wasn't appropriate. This is just how it looks in the review of the past entered data. So now in scrolling back up, after having reviewed this 6th chart with you, I've done all 6 of the required charts. I'm now able to close out this data cycle, and I'm going to do so now. So I'll close the data cycle. And in doing so, my project homepage will be updated. I'll open the Well Visit chart review again. And now, instead of the Enter Data button, I have an Analyze Data button. And we'll go into this in a little further depth, but you can feel free to explore what happens when you select the Analyze Data button, or if you want to select a report, what elements you may download from there
and include to review your data, be it in a raw format, your individual data, project, or group data.
You've reached the end of this first webinar, Laying the Foundation. I'll conclude with a couple action items for your team meeting or for your individual meeting as you prepare for your next steps. And once you complete this webinar, there'll be a post-webinar test comprised of several questions just to evaluate that you have reviewed this webinar, and it sends notifications to our project team. It's just one way for us to track and monitor the information that you've accessed and help you achieve your MOC Part 4 credit. So, in wrapping up this webinar, I hope that you move forward and consider, if it's possible, to not only create and foster an engaged and empowered clinical setting, but to maybe do this in a team fashion, in a core quality improvement team. If that's a route that you choose and can go, host a team meeting. Communicate the purposes of the Parenting at Mealtime and Playtime Quality Improvement Initiative, and highlight individual team member skills, and try and keep those skills in mind as you prepare for upcoming activities, and hone in on an individual's strengths and play upon that as you integrate their role into this project. It's helpful to discuss time commitments and their level of involvement and how you foresee this not only affecting their workload now, but as you get more comfortable with it, how it'll play out in the future. If you're going to be going about this by yourself or as a team, you want to finalize your baseline data collection. I hope I've clarified any questions around what items we're looking to evaluate in your first 2 cycles of data, 1 and 2, from August and September of 2017, that you can gather and abstract from 6 patients for each cycle. Again, those well-child visit age ranges are denoted on the KETA website within this module, and the number of charts that you have to review for each. After you've completed that information and entered it onto the project homepage, you can now begin the e-learning session module. And this module will award you with your MOC 2 credit that upon viewing the webinar that Dr. Amy Sternstein and Dr. Liz Zamuda have recorded for you and reviewed the literature and answered the 50 questions that are associated with it, you'll get your MOC Part 2, as well as the foundational background and scientific literature base that we've used to create our Parenting at Mealtime and Playtime handouts.